Hello, everybody, and a warm welcome to our today's session on shifting from volume to value in global healthcare. I'm Sandhya, here to take you through the discussion, and I'm delighted to have you all with us. Before we dive into the discussion, a quick introduction to who we are at Stellarix. We are an innovation and strategy partner that focuses on understanding real challenges and helping organizations determine the best path forward. We combine research, technology, and strategy to support companies at different stages, whether it's understanding a challenge, exploring new ideas, testing what works, or taking solutions to market. Our work cuts across areas like digital health, medtech, robotics, advanced materials, mobility, and sustainability. So we get to see a wide range of innovation happening across sectors. Over the last few months, our team, including me and Arpit, we have been deeply involved in a series of VBHC focused engagements, along with a detailed survey to understand how health systems and medtech players are navigating the shift towards value based care. The insights we uncovered on care evolution, readiness gaps, and collaboration models form the basis of today's conversation. And with that, let me bring in my colleague and co researcher on this study, Mr. Arpit Sharma, who has spent over the decade helping global healthcare organizations shape their VBHC transformation strategies. Arpit, why don't you walk us through how the delivery landscape has evolved and highlight some of the key signals we picked up through the survey?
Sure, Sandhya. So thank you for inviting me. To understand where the value-based healthcare is going, it's important to understand how we got here. So if we divide the entire phase into the four main parts. Before 2010, the US-based healthcare system was largely a volume-driven model. The payments were tied mainly to the activities like admissions, the scans, the procedures, and CMS has begun experimenting with the quality reporting and even the early bundled payment pilots. But these efforts were still limited in the scope, such as towards the hospital-acquired condition or certain orthopedic and cardiac procedures. Post 2010, with introduction of the Affordable Care Act, which is popularly known as the Obamacare, the the direction of the entire system has changed. The ACA has credited or created a structural backbone for the VBHC, and the High-Tech Act has accelerated the shift towards the digital data. This period has brought several changes, like rapid EHR adoption, the legitimization of PROM or PREM, which is the patient-reported outcome and the patient-reported experience, the early integration of the wearables into the clinical workflows, and also the growth of accountable care organizations, which became the test beds for the VBHC model. And in the third stage, that's the post-COVID, the another shift is observed, which is the care moved from the hospital to home. And almost this is done by necessity. The technologies like telehealth, the remote diagnostics, the remote patient monitoring, API-driven data sharing model has enabled the VBHC to become more real-time and more distributed. Yet, even with these shifts, the future direction of VBHC remains uncertain. And to explore this, we conducted the study and where we surveyed the payers, providers, the accountable care organizations, medtech companies, investors, and even the startups to understand how the VBHC is likely to evolve in the next decades. And we observed that the VBHC would grow around the three main levers. The first one is that the reimbursement will shift from hospital to home-based care. The second is the entire data collection process will be more holistic and the contracts were driven based on the holistic data. And the third would be that hyper-local micro VBHC model would be built on the segmented data, hyper-segmented data. And I will come to that in the next few slides. So the first question we asked to the respondents is what they believe exists today in the VBHC but will disappear in the future. And many believe that the VBHC has some structural limitations, such as the provider reported outcomes introduce a lot of bias. Even the relevance of VBHC in the acute care, such as in the orthopedic procedures or the cardiac procedures, may decline in the future because the concept of VBHC is mainly designed for the chronic conditions. And for the acute condition, probably the existing bundle-based payment models will continue to exist. And the other some, you can call as a wish list of the respondents is that the annual VBHC scorecards are very slow and possibly they are detached from the everyday workflow. So they might cease to exist in the future. And what's more interesting to find is that the micro VBHC model with the AI nudges, which will act as a measurable value units in the future. And these would be the sharp models, small models, developed, learned, which are created based on the small set of population data. Uh, they would flourish more in the future instead of the models which are built on the large data and the mega contracts that are being done today. The second is the API infrastructure, which is currently limited to certain data sets only, but will expand in the future for piping more vital related data, the medication data, the lab data, the patient adherence data, and even the social data as well, and even perhaps the environmental data as well into the VBHC contract. And also, the and this will lead to the alternative risk scoring models and more personalized risk scoring models that's dependent on the data from the nutrition, the digital phenotyping, and so on and so forth. So all from the data collection, data analysis to the accountable care. Uh, the VBHC is expected to be more holistic based on the respondent's view.
I think that aligns perfectly with what we have been analyzing together, Arpit, and feels like the right moment for us to take the conversation into the next segment and shift our gears. As we were reviewing the responses, two threads emerged very clearly, but they really need to be treated as two distinct conversations. First, there's a whole question of how workforce roles will shift over the next decade. The signals around skills, responsibilities, and maybe what clinicians will be expected to deliver in a VBHC driven system, they are hard to ignore. On the other hand, there's the issue of the underserved markets, which came through as the largest VBHC gap, but also the biggest opportunity, especially when structural access and affordability challenges are still dominant. So let's unpack these a bit, and Arpit, maybe you can add your perspective as we, build on this together.
Sure. So Sneha, I will come to the perspective in a later stage. First, we'll discuss on the how the roles of the workforce will shift in the next 10 years. And for this, we have asked the respondents for different roles. And what are the prominent roles we observed are projected on the slide. So on the bottom, the red quadrant, you see from where the shift will happen, and the white quadrant is to where the shift will happen. So coming to the first role of the billing and coding clerks, this we believe is the most impacted role, and the effect will be observed in the next 1 to 2 to 3 years, where the role will shift from manual billing, uh, which is the per service coding, to more bundled payment specialist and AI billing analyst. And this is the area where perhaps the shift will be more faster. The second is towards the hospital admission and discharge clerks, who currently works for the role which is tied up to the maximizing the patient throughput. They would more change towards the care coordinators and the transition management. Now, in the next area, like in the 5 to 8 years, the roles of the sales team or maybe the marketing of the VBHC, the payers and the providers need to change. And those who are doing the volume-based sales representatives, which are doing the volume-based sales today, would have to shift towards the HEOR specialist. And this is what even the large corporates have started asking the questions that how much amount of diabetic management you have done in the past 5 years. So the sales team has to be more equipped with the skills of the medical background so that they can answer the questions in a more clear and convincing way. Even the claim reviewers who are reviewing the claim for the individual basis right now, perhaps would be doing the population health assessment in the next 5 to 7 years. And further, in the 9 to 10 years, the diagnostic technicians, which are currently doing on an individual device basis, would more transition from the individual to a group level analytics. more done through the remote monitoring, the digital diagnostics and technologies. And even the supply chain middlemen would become the VBHC procurement analysts going forward. And one of the interesting finding that we got, as you discussed about the underserved market, and which is real innovation, which is really a area of innovation for the smaller companies and even the smaller investors, because this is an area where the large companies and they would not be willing to work more upon. So despite what we have observed is that goals of the Medicare and the Medicaid, the respondent highlight that there is a huge gap in the persistent access to the policies and also to the digital data. There is a infrastructure limitations, and there is a huge challenge about the digital literacy, both among the payers, the providers, and also the patients. So these are the factors that is creating a friction in the VBHC adoption and modeling it to the scale. So, however, these gaps also represent the largest opportunity, especially in the areas where the companies can work upon the frugal devices, the areas how to collect the data from the population who are digitally unaware, how to collect the community-based micro VBHC models, especially for the populations who are underserved currently, how to do the partnership with the NGOs and the employees, and developing the low cost remote care workflows would be the key differentiators where if the company work on these particular few of the areas, they can really not only serve the social market, but also take it as a business strategy for them. So the startup can define the value more broadly if they serve the underserved population area by including the access, by doing the financial projections, by developing the productivity, and finally doing the community benefit.
Yeah. Absolutely, Arpit. I think that connects well with what we both noticed while reviewing how workforce capabilities and access issues play out on the ground. Now, moving ahead, since a lot of participants today represent industry players, innovators, and even some early stage investors, let's bring the conversation to where the real traction points lie. One thing we discussed while finalizing the report was how the recommendations, opportunity areas, and entry pathways all tied together. So instead of posing this as a direct question, let me build on what you have just shared. As we translate these insights into action, whether for new entrants or established players, it becomes clear that there are few strategic levers that matter more than others. Let's explore these, the recommendations emerging from the survey, the white space areas for newcomers, and what someone with an existing business can practically tap into. Please walk us through these, how these pieces connect.
Yes, Sanjay. So, as we know, where the real gap lies, and that's is the experience and the indirect cost. So, while the outcomes and the direct cost receive the most attention, the respondent highlight a different gap. And the major area of the underserved, which where more innovations are possible, are towards the patient experience and the indirect cost. If we directly look at the equation, so the value is equal to the quality upon cost, and the and we see the quality is equal to the outcome plus the patient experience, and the cost is equal to the direct cost plus indirect cost. In terms of the patient experience, where the companies can really work upon is towards how to increase the communication between the payers, providers, offer the referrals, and so on. How to reduce the waiting time, the navigation ease, and even the emotional support, continuity of care, and how to make a PRO and PREM say 2.0 in this particular model. How, and the second area is how to reduce the indirect cost to the patient, how to compensate for the lost productivity, how to manage the travel cost of a patient and even for the caregiver support, how to offer a long-term, say, social security to the patients. So these are some areas where these are the real gaps that the society is facing with the disease burden. And perhaps here the VBHC has not yet entered. And these becomes the real opportunities for the companies and the startups to bring a differentiated value in the market. And where to make the micro VBHC models. So what we have observed in the study is main towards the three zones. So the first zone is a startup friendly zone where there could be a high predictability, where there is a strong data signals and there is a clear outcome. So the companies can work upon these areas to achieve the early, entry into the market and taking the growth into it for developing the micro VBHC bundles, the AI nudges, and even offering the digital coaching. The second area which comes in is where there is a moderate predictability, but there is a strong long-term demand, which are related to the obesity, the GLP-1 optimization, the behavioral health, the maternal health, and here the companies and these areas are very suitable for the mid-stage startups. So once you have entered into the model, and if you want to achieve the growth, this is the second stage where the companies can work upon. And then there are the third stage of the VBHC, which we have referred as the moonshot zones, where there's a high complexity, long validation cycle, and also a limited predictability. So these areas are the best suited for the deep tech startups or maybe the investors who are looking for the longer time zone. And and the final, we always asking why we are focusing more on the startups and the early stage investors, because there is an opportunity for them. And respondent lean towards the smaller and more adaptive organizations can play a better role. And why? Because because these areas require a capability that large incumbents perhaps will not prioritize. These are the capabilities where the startups can bring are the local customization that include the local models developed based on, say, a small location of population, uh, smaller organizations, same occupational hazards, maybe for, say, the people who share the same behavioral models and so on. The second is behavioral and operational change enablement, because large companies will mainly work on the standardization, whereas VBHC is more customization. And this is the area where the startups can create a major impact in the entire domain. It could be related to the data collection, the data analysis, even the ACOs workflows for the patient and the caregivers. The third area why the large company would not be interested in these areas, because the real world data collection in an unpredictable environment is really messy. And the startups has more, they work on a clean slate approach. They work on a frugal innovation model. So they can provide a more distributed care. And the last is the large companies would not have the cushion to do the rapid experimentation and iteration. And this is the area where even the startups can play a role. And the core message that comes from here is that as healthcare shifts from volume to value, the most meaningful opportunity often lies in the layers where the large organization do not reach or cannot address quickly enough, which the smaller organization can do. And here I'm just suggesting few of the areas where the companies or the startups or small investors can start with, or if you have already invested, you can move into some of the other areas based on the cushion available with you. And with this, I'll just take a conclusion of my webinar. So VBHC is expanding, and which is being observed from the study as well, and even everyone can observe it. And even you can build a solution around to make it more impactful and commercially sustainable. So if you're a medtech companies, payer providers, startups, or investors who are exploring the VBHC opportunity, we can offer you more similar insights, can develop a go-to-market strategy for you, help you in developing the business model design, and creating the ROI pathways. That's all from my side. Sandhya, over to you.
Thank you. Thank you so much, Arpit. Really well said, and it's been great, unpacking these insights together. And the way you outlined the opportunity landscape, that adds a lot of clarity for everyone tuned in today. And for the audience, just a quick recap what we explored today. We explored the evolution of VBHC, the signals from the survey, the workforce access dynamics, and the practical entry routes for organizations at different stages. Um, I would like to say that we are at a pivotal moment where, outcomes, not activity, are becoming the language of success across healthcare. As we wrap up, if you would like to explore any of these themes further or discuss how they apply to your organization, the contact details are on your screen. Our team would be happy to continue the conversation. Thank you once again for joining us, everybody. Stay tuned for more sessions. And until then, let's keep pushing healthcare toward a future that truly rewards better outcomes. Have a wonderful day. Thank you.
Thank you.